Hello, and welcome to the Making Medicaid Data More Accessible Through Common Data Models and FHIR APIs webinar series. Before we begin, I'd like to provide a brief overview of this project, which addresses the federal priority to expand data capacity or data infrastructure for conducting patient-centered outcomes research, abbreviated as PCOR, that informs decisions about the effectiveness of health interventions used in Medicaid and children's health insurance programs. The Transformed Medicaid Statistical Information System, known as T-MSIS, has analytic files that are suitable for research, known as TAF-RIFs, as part of a new research-optimized national Medicaid dataset that begins in 2014 with full representation from all jurisdictions by 2016. These files include data on Medicaid and children's health insurance program enrollment, demographics, service utilization, and payments. This project created open source code to format these data into the FDA Sentinel and Observational Medical Outcomes Partnership common data models to improve data access, to accelerate analyses, and to enable multi-database studies. The aim of this webinar series is to educate researchers who are using or plan to use Medicaid data and about the new data transformation tools developed in this project, as well as to disseminate major findings. Each video in this webinar series is a chapter that covers a key project objective. I'm going to be talking about Chapter 4 today. My name is Judy Morrow, and I'm from the Department of Population Medicine at Harvard Medical School and Harvard Pilgrim Healthcare Institute, and I'll be leading the chapter which discusses data quality metrics in U.S. Medicaid data, results from Sentinel's Medicaid Data Mart. Please note that the views expressed in this presentation are those of the authors and do not necessarily represent the official position of the U.S. Department of Health and Human Services or the Food and Drug Administration. The work discussed in this presentation was funded by the Office of the Secretary Patient-Centered Outcomes Research Trust Fund, which was made available to FDA by the Office of the Assistant Secretary for Planning and Evaluation through an interagency agreement. The US FDA funded the Sentinel Initiative contract. I am an employee of Harvard Pilgrim Healthcare Institute, an organization which conducts work for government and private organizations, including pharmaceutical companies. So our agenda today has two parts. First, we'll talk a little bit about the background of this project, and then we'll look at some of the specific data quality metrics that were produced from Sentinel's 2014 through 2020 T-MSIS data mart. So let's start with that background. First, let's talk a little bit about Medicaid data and what it is. It is data about beneficiary enrollment and eligibility, utilization and claims, and expenditures for people covered by Medicaid or the Children's Health Insurance Program. Medicaid and CHIP combined provide healthcare coverage to millions of Americans of all ages, including eligible low-income adults, children, pregnant patients, elderly adults, and people with disabilities. In 2010, the Patient Protection and Affordable Care Act included a provision to expand Medicaid eligibility to adults up to age 64 with incomes up to 138% of the federal poverty level. And as of May 2024, 41 states and Washington, D.C. have adopted this Medicaid eligibility expansion provision. So how are these data available to researchers? States and territories administer health insurance programs and submit their enrollment and claims data to the federal government in the Transformed Medicaid Statistical Information System, or T-MSIS format, starting in 2014, with all states complying by 2016. T-MSIS research identifiable files are produced in yearly increments, and that makes an approximately 2-year lag before data is settled. There is an earlier submission system known as the Medicaid Statistical Information System, or MSIS, which was used prior to the T-MSIS dataset. And for that, there is a Medicaid Analytic Extract file, which is a research optimized file that was created. Those file structures were retired in place. So with that, we'll spend a minute to talk about why we might think about data quality and how data quality is important to the FDA, in addition to other individuals who contributed to this project. So one of the things that CMS makes available to researchers is a tool that is called the Data Quality Atlas. And there's a link that's going to be included in the comments section and is also shown on the screen. And this Data Quality Atlas explores the quality and usability of Medicaid and CHIP data in T-MSIS analytic files. And so we're just going to walk through an example of how we use these data sets in order to start with our very first idea about data quality and whether we can include data in a research-ready or surveillance-ready data set. And so this is a screenshot of a particular topic within the Data Quality Atlas. You see that on the left that you can search for a topic within the T-MSIS data set. So that can be a variable or a field. These data are available in yearly increments as well as separated by jurisdiction, and then also by the release of that data. And so on the right, in the lower right-hand corner, you see an assessment, and that assessment is for the particular variable shown on the screen. Here, it's the comprehensive managed care plan encounters in the inpatient setting. And so you see that there's a ranking of whether each jurisdiction and year and release version has data that are of a low, medium, high concern, or they're deemed unusable or unclassified. And so this unusable criteria is an important one that I'll talk about in a minute. And it's one that we use as a factor to decide whether or not to include these years and jurisdictions in the data set that we use in the FDA's Sentinel system. So we have many ways to think about quality assurance, and we start out with this very high level where we look at all the data that are available, and we say, based on the Data Quality Atlas assessment, we want to understand if there are various state Medicaid databases that have characteristics that the Data Quality Atlas has deemed unusable. And we're going to particularly focus on characteristics that are important for P-core research. And I'll talk about that in the next slide, what those characteristics are. So that's going to be our first cut of whether we include or exclude data from our data set. After that, we're going to take a detailed look at the remaining data years, and we're going to look particularly about their distributional characteristics, and we're going to characterize that data because we want to understand if any given state or jurisdiction plus year plus plan is of suitable quality to be included in pharmacoepidemiology or P-core work. The third level of data quality assurance we're going to talk about in this presentation is to think even more about whether the particular metrics are important so that we can deem the data fit for maternal health studies. And so there are a number of the metrics that we're going to talk about today that are really specifically geared around doing studies in maternal health and using these data sets for that purpose. So let's go back to our thoughts about the Data Quality Atlas. So there are many variables in the data set itself. And so we only chose a few to sort of focus on for the purpose of inclusion or exclusion in the data set at the very highest level. And FDA's requirement for pharmacoepidemiology studies that are performed in the Sentinel system is really centered around this concept of complete capture during an enrollment period. And so what does that really mean? It means that we want to be assured when looking at longitudinal data for any given patient that if we do not see an event there, so the absence of that event is truly an absence and isn't just missing. And so we want to be very reassured that we have complete capture during this period of all medical utilization and any pharmacy that we see. And so there are fields that have been designated through the Data Quality Atlas that we say cannot be marked as unusable, because if they are marked as unusable, we won't allow them into our data set that is surveillance and research ready for P-core work and particularly maternal health work. And you see those particular variables written on your screen there. You'll note that completeness is a word in many of the variables because that, again, is really the main point we're looking for when we decide whether or not these data are going to be included and part of future studies. And this is an example of what we do when we assess these data. So this is just the first couple of alphabetical rows that you see here. All the way on the left shows the jurisdiction. You see that there are differences between the fee-for-service data feed and the comprehensive managed care data feed. And you see there's an assessment of every year, and these data are assessed for the second release or the final release of that year. And so there are certain jurisdictions where all the years are included because all of those data points in the Data Quality Atlas were not deemed unusable. You'll see that there are other jurisdictions where every single year has a data point, a critical one, that was deemed unusable. And so they are not included in the data set that we are going to talk about today. And we go through this process whenever we add data to Sentinel's Medicaid data mart and think about each particular year and jurisdiction and plan type being fee-for-service or comprehensive managed care, when we think about whether these data are fit for purpose for PCOR research. So in the end, the number of jurisdictions that are included in Sentinel's data mart are shown on your screen. And I want to note that in the years 2014 to 2015, that's the transition period between the MSIS and the T-MSIS system and between the MAX analytic files and the TAF RIFs. And so those have a notable incompleteness during those years when there was a transition period. Following that, you'll see that we continue to see that there are improvements in data quality that allow different years to be added, different jurisdictions per year to be added in each of the plan types as we move forward, and we hope to see more added still in the years to come. So once we go through and we do our initial assessment using that data quality atlas, we then transform data into the Sentinel Common Data Model, which is the subject of other chapters within this webinar series. And then we perform a standard Sentinel data quality process. And what that does is it does a series of data quality checks, actually more than 1,600. And those checks are looking for particular things. You see them highlighted on your screen here. There are checks for the completeness of data, for the validity of data being in the right format, for the accuracy of data within a patient's longitudinal record, for the integrity of data within that patient's longitudinal record, and for consistency of data over time. Because we annually increment this data set, we are looking for whether there have been abrupt changes from year over year when we add new data. And so that consistency is always an important part of our process. So the goals of this particular project were to leverage the ASPE-funded data quality metrics model to characterize data quality, particularly for PCOR work and in mental health. And how do we do that? We created a panel, a technical expert panel of folks that had particular experience in using Medicaid data and also in common data models to select 30 metrics, data quality, that they thought would be useful to researchers so that researchers could decide whether these data were fit for purpose for particularly maternal health, but more broadly, PCOR work. And that once those metrics were selected and then populated, that we would develop training materials for the public, of which this webinar series is a part. And so let's look at the results. So what we've done now is we've taken the 30 metrics that were selected by our technical expert panel, and we have applied them in Sentinel's Medicaid data mart, which has data ranging from 2014 to 2020. And so let's look at what those 30 metrics were. So they fall into 5 categories, which you see on your left. There are demographics, there's enrollment, there's utilization information, there's death information, and there's orphan records. And so I'm not going to go through and read all 30 of these metrics, but just know that generally they fall into 1 of 2 categories. They're concerns about whether data are missing in various proportions. And then the rest of these characteristics and metrics are more about looking at distributional statistics of particular data points across the data set, both overall and then within jurisdiction, year group, and then in some cases, plan type. And so this is a way that we can use data from various jurisdictions and benchmark it against other jurisdictions to see if we have any outliers or other database characteristics that might cause us to investigate why there might be particular differences when we go from jurisdiction to jurisdiction. And so we'll see these as we go through the metrics in turn. We're going to start with the 9 demographic metrics, which are shown on your screen, and we're going to show visuals of each of these demographics. So we start with demographics that relate to missingness in the overall demographics of the data set. And we start with a proportion of patients with missing sex. And you'll see in the upper left-hand corner is the overall rate of missingness in the entire data set. You'll also note here that there are certain jurisdictions that are shown in white, or they might look like gray on your screen. And they're shown that way because those were jurisdictions where there were no years of data that were included in Sentinel's data set because they had not had characteristics that were deemed usable by Data Quality Atlas of the ones that we saw in that first screen. So you'll continue to see that there are certain jurisdictions that are missing throughout these metrics that you see, and that's why they're missing. So back to the particular metric here with the proportion of patients with missing sex. We know that in administrative claims databases, and Medicaid is one of those, that missing sex is very unusual. And so this is very in keeping with our expectation for this type of data. Similarly, this next slide is about the proportion of patients with missing date of birth. And also in administrative claims data, we know that missingness is quite rare. And so we see that reflected here with very, very small numbers of missingness. Now we're going to talk a minute about the possibility of missing race and ethnicity in the TAF RIF data sets. So it's important to think about how this particular variable is defined. In the 1990s, the Office of Management and Budget specified that there was race and ethnicity were to be separately defined with particular levels or categories of types of race and types of ethnicity for all federally collected data. And that has recently changed. And so very recently, the Office of Management and Budget announced that they would be creating a combined race and ethnicity category with a multi-select functionality that would be implemented by 2029. But up until this point, race and ethnicity have largely been separated in many federal data sets. And this is an exception. The T-MSIS data set has a combined race and ethnicity variable. And you can see that for particular values, so we're going to focus right now on when ethnicity is populated as Hispanic or on your screen as code 7, then this variable eliminates further race designation in the source data. So we know that individuals might be Hispanic, but we don't know if they are white or if they are Black. Or if they have another race. Similarly, you can see that for the Hawaiian Pacific Islanders, which has typically been regarded as a race category, there is no designated ethnicity. And so what this does is in data sets that are adopting the structure where there is a separated race and ethnicity variable, this can result in missingness because there is not a separate variable here. There's a combined variable in the source data. And we'll see that reflected here in these next two slides. So first, let's look at the proportion of patients with missing ethnicity. Overall, missing ethnicity or unknown ethnicity is right under 20%, so right under a fifth of the data. And you can see that there's quite a bit of heterogeneity here. We have proportions that are running as low as 10% or so, and then we have things that are in excess of 80%. So there's a lot of heterogeneity in the jurisdictions that you see here. On the next slide, I'm showing you the proportion of patients with missing race. And this is much higher. So whereas 18% or so had missing ethnicity, 40% or so have missing race when we convert these data into the Sentinel Common Data Model, which has a separated race and ethnicity variable. And you can see that the jurisdictions that have very large Hispanic populations have that higher race missingness. And that's because of in the source data, where it is sourced as saying Hispanic all races, there is not a designated race for people of Hispanic origin. And so here you see that reflected, for example, in Puerto Rico, which has a very high Hispanic population, and to a lesser extent in Texas and California. But there's also quite a lot of heterogeneity here. So you see that some jurisdictions have very low missingness and others have quite high missingness across the board. This next slide is seeking to capture the data set at one point in time and record the age of everybody in the data set at that time to give a sense of the difference between pediatric representation and adult representation in the overall data set. And the snapshot that these data are taken at is at the last day of data availability for that particular jurisdiction. So for many of the jurisdictions that you see here, that's going to be December 31st of 2020, which is the last date in the data set. Over on the left, you see that 00 at the top, that means overall. So the overall proportion of in utero, infant, and pediatric patients in the Sentinel Data Mart is just under 50%. And you can see, of course, that then the remainder are adults. And so what we're looking at here is, again, to understand a little bit more about the heterogeneity between jurisdictions. We see that some large states like Texas, Florida, and Georgia have very few adults enrolled in Medicaid. And you can see that reflected because their bars go all the way across the screen, getting close to 80% of their data sets that include pediatric patients only. Another unique characteristic in New York, you see a substantial number of in utero patients. That is a uniqueness about how New York assigns their enrollment start dates for patients. And so it's another thing, just to a quirk of the data, to keep looking out for these jurisdictions and how they vary and how that might impact research that you're looking to do. So next, we're going to take another look, keeping with the maternal health concept here, about the proportion of patients of childbearing age, which here is going to be your 10 to 54-year-old persons. And so the overall proportion is 35.45%, but there's actually a narrower range here across all of the jurisdictions represented in the T-MSIS Sentinel version of the T-MSIS data set. And so most of them are right in this 35% range without too much variability here. You do see, though, that some of the states that were previously shown as having few persons who were adults in the data set, there's some parallel here because most patients of childbearing age are in fact adults. And so next, we're going to look at the distribution of age at live birth delivery. Again, a characteristic that's particularly important if you're thinking about doing maternal health research or core research that emphasizes maternal health, to understand a little bit more about what type of pregnancies are being captured in this data set. And so here, of the 6.7 million live birth deliveries that are included, the median age at delivery is essentially mid-20s. And in all of these distributional statistics slides, you'll note that the interquartile range, or the 25th through the 75th percentile, is shown here on the screen, with the bars extending to the whiskers at the 5th and the 95th percentile, where the median is where the line is in the middle of the interquartile range bar here. And so another thing that you can tell from looking at this is that only 5% of deliveries are among children or pediatric patients. And so with that, we'll move on to our enrollment characteristics. And so right now you see that there were 6 enrollment metrics that our technical expert panel advised us to go ahead and collect and measure, and then create figures to look at. So let's take a look at what we have here. Enrollment is very important to PCOR studies because it directly relates to the follow-up available for any given patient. And here I want to show you the distribution of the length of contiguous enrollment for patients that have at least a day of medical and drug coverage in the Medicaid data set. And so here, when you look at this, there's quite a bit of heterogeneity in your interquartile range. But of the 147 million enrollment spans that are included, overall median contiguous enrollment is 18 months. And there is a mean of 25 months, which is created from a couple of jurisdictions that contribute particularly long enrollment spans. When we see shorter spans, for example, in the jurisdiction in Tennessee, that sometimes happened because there has been data that have been excluded due to those earlier exclusion criteria associated with unusable data per the DQ Atlas. And so when we have those excluded data, that looks to us like a shorter contiguous enrollment span because that some of those data years are no longer included. When we look at this all together, we can tell that 75% of the patients that are covered in the Sentinel Medicaid Data Mart have at least 10 months of coverage. Now, if we think about what type, we want to make sure that when we do PCOR research, we are able to understand whether the data there that are reflected are truly the data that we're seeing, or if there are some artifacts. And what I mean by an artifact is, as a consequence of us excluding particular years, we may have created this artificially shorter enrollment span. So we can also look at these data by removing those jurisdictions where there were exclusions that were made to them. So when we do that, we can take a look at this same data set, but we can look at it amongst only jurisdictions that had what we can think of as complete data over the period of concern, so between 2014 and 2020. When we remove those, what I'm going to call discontinuous jurisdictions, meaning that they may have a data year that was removed in the middle, like 2018 or 2019, then we see that the median contiguous enrollment, and here we're weighting it because we don't have a true median, it rises to 22 months with a mean that also rises to 28.5 months. And you can see in the lower right-hand portion of your screen which jurisdictions were removed because they had discontiguous data. And so in addition to contiguous enrollment during one particular period of time, we might also be interested in cumulative enrollment, which is what we're going to look at on this next slide. And here with cumulative enrollment, this might occur because a patient may have Medicaid coverage for one particular year, and then they have a break and they become ineligible for coverage, perhaps for another couple of years, and then become eligible again. And so we might be interested in their cumulative enrollment in addition to their contiguous enrollment. And so of the 105.7 million patients included in the data set, overall median cumulative enrollment is 33 months. And again, when we do see shorter spans, those largely result from jurisdictions that have excluded data. 75% of people or patients have at least 13 months of total coverage. You also, though, can see that there is, again, a lot of heterogeneity in these jurisdictions that you can see represented here by the interquartile ranges across. I should also have noted earlier in the presentation that the ordering of the jurisdictions from the top of the slide to the bottom of the slide is based on the total patient count, so that you have states that are more populous shown in the top part of the screen, and you have states that are less populous shown in the bottom part of the screen for that particular metric. And so when we look at enrollment, we have often questions about when people do in fact lose eligibility and have a discontinuity in their enrollment path. What is the length of that gap before they then have eligibility again? And what does that gap look like? So overall in our data, we had gaps that were most commonly a single year with a mean of 13.8 months. And primarily this is an artifact of the way that we excluded certain years in our data. So for the same reason that we see that there may be shorter spans, we might also see these gaps that are particularly 12 months because we've excluded explicitly 12 months, 1 year group was not included per year. So just like before, we might want to take a look at these data where we take out those discontinuities that are happening. And so when we do that, when we take out those discontinuous jurisdictions, the gap length now shrinks to a median of 7.5 months. So this is the break between coverage periods for these states where you have complete years from 2014 through 2020 in the data set, and a mean of 11.3 months. And you could see that there is, reasonable amount of heterogeneity, but it's mostly on the long end length of the gap. So that for certain sets of patients, there may be very large gaps, in excess of 2 years before we do see that they're going to get back on Medicaid. And so there aren't as many brief breaks, but for some people, there are quite long breaks in between their Medicaid enrollment periods. And now we're going to look at a different kind of gap. So this is the gap between when an infant is born and the date of their first enrollment in Medicaid. And again, this is really particularly important for PCOR and maternal health researchers, because we know that in administrative claims data, that a child may not have information about them represented on their own individual record until they have that date of first enrollment, but that it can considerably lag their date of birth. And that administrative gap is something of concern because we actually think that they are being covered, that they are having medical services during that time, but administratively, it may appear that they are unenrolled. And so we're curious about how that gap looks like in these different jurisdictions. So overall, of 13 million births in these data, slightly greater than 50% of infants are enrolled prior to birth, which is great news for us when we look to follow a child from the date of birth on. But 25% are enrolled after 40 days following birth. And there are some very long tails in this data set so that you can see that some individual jurisdictions have children that are not enrolled, for more than 6 months after they're born, sometimes more than 8 months. Also, again, when we look at these relative to other jurisdictions, you notice outliers and patterns. So that you see in New York particularly enrolls patients early. And so there are many, many more patients that are enrolled prior to birth in New York, which, if you recall from the earlier slides we showed, leads to that more substantial in utero population than in any other jurisdiction that we see in this data set. And so, keeping with enrollment that is more particularly important for maternal health research, we can look at the duration of pre-live birth delivery enrollment. And what we mean by that is we want to understand how much of the pregnancy and pre-pregnancy period might be covered for any individual patient in the data set. So of 6.7 million deliveries, 50% of pregnant individuals have greater than or equal to 9 months of pre-delivery enrollment. So what we can think of is basically the entire pregnancy. States with shorter pre-live birth enrollment include Texas, Florida, and Georgia. And so in those particular jurisdictions, when thinking about studying them, for example, if we need to study something that happens right around the date of conception or the last menstrual period, we might not have data there. It might be missing because they have shorter pre-live birth enrollment spans. And so this is really particularly important when we're thinking about conditions that are either just pre-pregnancy or right at the point of conception period when we're doing work. In addition to looking at that pregnancy period, we might be also very interested in the postpartum period. How long can we follow individuals after they have delivered in the postpartum period for further PCOR work or maternal health assessment? So of 6.7 million deliveries, 75% of postpartum individuals have greater than or equal to 3 months of post-delivery enrollment. And here, when we look across, there is a lot of heterogeneity in each of these jurisdictions. Texas is a notable outlier of very short postpartum coverage. And so this is really important when researchers who are thinking about doing work in the postpartum period, understanding whether there may be missingness in these data, missingness that might be a fatal flaw in terms of measuring something that is happening postpartum when that postpartum period might be reasonably 6 months or 9 months long in terms of the measurement scheme in a particular study. And so with that, we move away from enrollment and into our third category of metrics. We look at utilization. Now, here in utilization, we're going to be looking at different types of medical visits and pharmacy. And we want to see here what our use looks like across all of these jurisdiction years. And what we're particularly looking for is characterization of these to spot outliers. If there's anything here that might be unusual, that might call us to think about if there are data quality issues associated with our PCOR or maternal health work. So here I'm going to talk about the proportion of patients who are enrolled, but they have no evidence of utilization during a particular time frame. So you could think of them as particularly healthy patients, perhaps, that don't have any interactions with the medical care system during this time. That overall proportion is just close to 11%. But it's important to note here that we do include, because we look at the different payer types, so that's fee-for-service plans and comprehensive managed care plans in this data set, we have some states where we have higher non-utilization when they only have fee-for-service plans that are included, but they do not have comprehensive managed care plans included. And in that case, What can look to us like non-utilization may just be people who are transitioning from fee-for-service plans to comprehensive managed care plans in our data when we're not including those comprehensive managed care plans because we have some data quality concerns. So this graphic is showing you the distribution of inpatient hospitalizations per year among patients that have at least one hospitalization. And so we look at this and you see that the data are more sparse in 2014 and 2015. Again, these are the transition years for the maxed TAF data set. And you see that it's arranged very similarly to the other graphics where we have the greatest patient population at the top of the graph on the left, and we have the smaller patient populations at the bottom of the graph. And then we're looking at each year, year over year, so we can see if there are any differences. So of 27 million patients who have at least one hospitalization, most only have one per year, which is great news. California, New York, and Massachusetts have notable populations that have greater than one hospitalizations per year, which you can tell from the interquartile range for those particular jurisdictions. We're going to do this with additionally emergency department visits. So this is a similar graphic that's showing you the distribution of emergency department visits per patient per year among patients who have at least one emergency department visits. And of 91.6 million patients with at least one emergency department visits, 75% of these patients have less than or equal to 2 visits per year. And so here you can see that the numbers are really, in this case, not as heterogeneous across populations. The interquartile ranges are quite stable. And so there's nothing that appears to be, something that might merit further investigation. Here we look at the distribution of ambulatory encounters per patient per year among patients who have had at least one ambulatory encounter. And so of 283, and this should be ambulatory encounters to not include the emergency department. So these are really office visits. So of 283 million patients with ambulatory visits, the median visit count is 5 to 6 per patient per year, and the mean is 9 to 12 per patient per year. So you can see that there are a small number of patients that have a large number of visits per year, and that's why that mean is pulling higher than that median. And if we look across the board, we see that there's more heterogeneity in these types of statistics because there is just a lot more volume of visits, and therefore there's quite a bit larger range of what's included here. Now what we're going to look at is our ratio of inpatient hospitalizations to emergency department visits. And so here our expectation going into looking at this metric is that there will be less inpatient hospitalizations than emergency department visits because of the acuity associated with inpatient hospitalizations. And so when we look at these ratios, we are looking to see if there are any that are outliers. And so what I have highlighted for you on the screen is Florida, Illinois, and Louisiana. And in these, the black dots, which is on a log transform scale, just so that it fits onto the slide that you see here, they have clear outliers. They're moving away from that middle bar. And these are jurisdictions where there are many more inpatient hospitalizations than emergency department visits. And this is a red flag for us because this might illustrate undercapture of emergency department claims or missing emergency department visits in these data. And so this is showing you for those particular jurisdictions so that you can contrast what jurisdictions look like where there might be, again, these outliers. So I'm showing you 3 different jurisdictions at the top of the screen where we have concerns that there may be more inpatient hospitalizations than expected, and we have other jurisdictions shown at the bottom of the screen where we may have less concerns. And you can see in particular here that Illinois is quite a standout, where there are many more inpatient hospitalizations than emergency department visits. And so there's a concern about where the missing emergency department visits are. You also will notice that the gross numbers here, so if you look at your scales, the absolute scales are just that there's many, many less, even for a fairly largely populated state. And so, again, the concern here is that we may be missing the emergency department component of it. And that's something that we use as a data quality metric to prompt further evaluation and investigation into these data. So this is a similar ratio-based analysis. Well, so here we have a ratio of inpatient hospitalizations to outpatient visits and emergency department visits combined. So here we're considering outpatient to be both ED and ambulatory visits. And we have another outlier here where we're looking for concerns, and I'm looking particularly in Florida in 2017 and 2018 as an outlier. And these are years in which the Florida data that we have included in the overall data set only includes fee-for-service patients who may be particularly frail and have higher levels of inpatient use. And you can see the difference illustrated here in this next graphic. You see that in Florida, and these are years across your x-axis, you see that there's these big dips in 2017 and 2018, and that's because in those particular years, the fee-for-service is the only patient population that's being represented because the comprehensive managed care population had data that were deemed unusable. And so they were pulled out of that population. And in addition to that, you can see then that they look quite a bit different in terms of their makeup than the other data points that you see on the slide. Again, if we go back across to the Illinois data set in the upper right corner, we have the absence of those emergency department visits that we're really concerned about. So we don't know sort of where those missing visits are. And that is, again, cause for further evaluation and assessment when we're thinking about setting up to do a PCOR study or a maternal health study, particularly if we're going to include data from that jurisdiction in our study. So this is the distribution of inpatient lengths of stay per patient per year in these data. So among 36.5 million hospitalizations that were included, the median inpatient length of stay is 4 days and the mean is closer to 8. And again, when we look at these data across years and across jurisdictions, we're looking for the degree of heterogeneity in these jurisdictions so we can understand if there are possibly there are different practices or anything that's going on that would cause, for example, a quite shorter overall length of stay or a longer length of stay on average. Here is a distribution of dispensing records. We've been talking quite a bit about the medical utilization, but in addition, we're very interested in dispensing records as the FDA is very interested in medication use per patient per year. And so median dispensing records per person is 1 to 2 dispensings per year, whereas the mean dispensing records per person is closer to 9 per year. So again, we have this pattern where the mean is higher than the median because there are a small percentage of patients that have very high utilization, either of medical care or of drug utilization, in this case, pharmacy benefits. And you're seeing, additionally, if you look in the year groups over time, you're seeing a little bit of difference too in terms of some of the dispensing, so that later in the years, there appears to be more dispensings per patient per year than some of the earlier bars when you look at this over time. So another data quality metric that we're interested in is the proportion of primary or principal discharge diagnoses out of all the total diagnoses in an inpatient claim per year, where a high proportion would usually, and a high proportion here is denoted, you can see some bars marked off with dots where there's a higher proportion, where there's a small number of diagnoses that are being submitted to T-MSIS for the inpatient claims. And so essentially, when a claim is submitted, it can be submitted with a variable number of diagnoses. And so certain jurisdictions may choose to submit very few diagnoses. And if that happens, then the ratio or the proportion of the primary discharge to the total number of diagnoses will be markedly different than in places where there can be 10 or 12 or 15 overall diagnosis codes that are submitted on the same claim for a given inpatient visit. So the next thing we're going to look at is the distribution of the number of diagnosis codes by setting. And here we have from left to right, ambulatory visits. So again, these are things that we think of as office visits, emergency department visits, inpatient visits, institutional stays, so these are things like nursing home visits, and then other ambulatory care. So you can think of in things like this as like telehealth or other types of care that usually does not involve face-to-face transaction with a provider. And so one of the things that's true is that Medicaid itself limits outpatient claims to 2 diagnoses codes per visit. And you can see that reflected here in the ambulatory, in the emergency department, and in the other ambulatory columns where there's solidly everybody is submitting 2 diagnoses codes per visit. But there's more variability when we look at our inpatient number of diagnoses codes per hospitalization, for example. And we see inpatient outliers include Missouri, Puerto Rico, and Rhode Island. Oh, sorry. The last one in this distributional characteristics section is going to be about the distribution of the number of procedure codes per encounter setting. So we're going to have, again, the same lineup of ambulatory visits, emergency department visits, inpatient visits, institutional stays, and other ambulatory. Here, we're drawing your attention to, of the 36 million hospitalizations, there are a median of 11 procedures per hospitalization. And of the 178 million emergency department visits, there are a median of 5 procedures per emergency department visits. But we see that Puerto Rico is an example of a jurisdiction that has many fewer procedures. And so, again, this helps us to understand just a little bit more about these data. It's not to say that any jurisdiction is doing anything wrong or that there is any problem. It's just that when we are thinking about assessing these data, again, we're really interested in ensuring that we have complete capture. And any sort of hint that we may not have complete capture is a cause for concern that might warrant further evaluation, investigation for whether or not those data should be included in PCOR or maternal health studies in particular. And so we're done now with our utilization section. So now we have our 4th out of 5th category, and this is our category related to data quality metrics involving death. There are a smaller number of data quality metrics in this area, and in particular, the Medicaid data set is it has information that can be linked to the National Death Index. And so death data is of particular importance, and it's very important for maternal health research because maternal mortality is a quite important topic, very popular in Medicaid and something of concern to many PCOR and maternal health researchers. So looking at our death metrics, just a comment on this, as you may have realized going through this slide show already, is that we have these very stringent inclusion criteria. And it's important to think about how that stringent inclusion criteria for whether data can be included or not included based on quality metrics in the data set, what that does to study conclusions. And so let's talk a little bit about that with maternal mortality rates. So on your right, you see some information that was pulled from the CDC website on the maternal mortality rate from 2018 through 2022 for various jurisdictions, and they are ordered from where the maternal mortality rate is highest to where, and it just, we didn't include all of them here just for the demonstration for this discussion. But you see that many of them, we put an asterisk next to that jurisdiction name, and these are jurisdictions where there have been some years that have been excluded because of data quality requirements. So it's very important to think about when you have jurisdictions where there have been partial exclusions for data quality issues, what that might do to your external validity or generalizability when you study these populations. So we tend to think first about prioritizing internal validity of studies by only including data that meets our quality standards. But that internal validity prioritization can mean that the conclusions that you might draw from any given study might not be reflective of the whole population out there. It might have more limited generalizability. And this is true of any study, but it's particularly important to be aware of this in a very large heterogeneous data set like Medicaid, where inclusion and exclusion criteria can be critical to think about in interpreting any results that come out of the data that are used in these studies. So with that, we'll take a look at some of these death characteristics. So the proportion of patients that have a death record among patients who have a hospital discharge status of expired. So what does this mean? When there is a hospital visit and a patient is discharged expired, that's another way of saying that the patient died in the hospital. So we would expect that of all of those patients that died in the hospital, that there would be a corresponding death record for those patients. And we see overall in the proportion in our data that 81% have a corresponding death record when there is an inpatient discharge status of expired. But we do see that there are quite some big differences in the outliers here. And we see that Washington and Arkansas have the poorest correspondence between patients that appear to have died in the hospital who don't have a included death record. This is some distributional statistics about the age at the time of death. And so of the 1.3 million death records here, 25% of deaths are recorded for individuals less than 43. So kind of a sobering statistic there, but important to think about and to think about the populations that are included here. This is a graphic that's showing the proportion of patients that have evidence of utilization following their death with a certain grace period for which we think that there might be late arriving data because of administrative issues. And that overall proportion is quite small. You could see here that Pennsylvania is a particular outlier amongst all the other states in having late arriving data or evidence of utilization that appears after a patient's death. The last data quality metric is one that we call orphan encounters. And these are encounters that we might see in the data set that don't have any procedures or diagnoses codes attached to them. And so when we look in this, we're interested in why those might be, why there might be orphan records. And when we did a deeper dive, we found that orphan records were almost exclusively medications that appeared on claims lines in the other services file. And so all of this is sort of a uniqueness of how the data are in Medicaid. 90% of them did have an accompanying procedure code, and almost all of them had a diagnosis code on the header file. So this is just the difference in how the data are contained in the data set and where they appear. And so this is something that is a very strict sort of data quality issue about how the data are being reported. And so we only have a singular characteristic to show here, which is the proportion of the encounters that lack the utilization. Again, there's not that many that have this characteristic, which is what we would expect and what we would want. But there are a few that have a little bit more than others based on potentially submission practices of those jurisdictions. And so our final slide, the quality metrics takeaways. First, Medicaid is really an amalgamation of 53 times 2 different data sources. And that's because each jurisdiction, which are the states and territories, have both fee-for-service and comprehensive managed care plans, and those data feeds are separated. And that means that there are that many sets of practice rules and procedures that can give rise to the heterogeneity we see in an overall U.S. Medicaid data set. The Data Quality Atlas remains an incredibly important starting resource to use to assess data quality. And while we have chosen particular variables and fields that are important for the FDA Sentinel system, as well as PCOR research and maternal health, we would invite researchers to use this resource to explore variables that might be important to their work and to think about whether there are jurisdictions that have data that are deemed unusable and whether or not those should be excluded from particular studies. Based on these initial results from the data quality metrics, we did use some of the data that we saw here to do further exclusions after we saw the metrics. So I'm going to give you a couple examples of that. In Nebraska, we saw that nearly 100% of inpatient visits showed negative lengths of stay. And that was created because there we had situations where the discharge date preceded the admission date, but we couldn't be sure of which was the more accurate number. Now, we have since that time come around to find alternative places to gather that information. But in the standard place that it's true for all the other jurisdictions, we were consistently seeing these negative lengths of stay that caused us to exclude that jurisdiction for a particular time frame. We also saw some instability in Florida, where there were years with obvious incompleteness in volume. And we would not have seen this characteristic if we had not done this very rigorous jurisdiction by year by plan type review. And that's what caused us to remove some of the comprehensive managed care data in Florida during that 2-year period of 2017 and 2018. And so it's important to use these metrics to really influence whether you think the data have such quality problems. And again, for us, a quality problem we're particularly concerned with is missingness or incompleteness. Whether we need to, think about whether to exclude those data or not. And then one final thought on this, that there's no right answer for many of these metrics, but both the cross-state or jurisdiction as well as the cross-year comparison provides a useful way to benchmark and therefore to identify outliers that might warrant further investigation or evaluation when preparing your data and understanding whether you deem it fit for purpose for PCOR or maternal health research. And with that, thank you for staying with me as we go through this very long chapter that we have in the data quality metrics. I've really appreciated all of your attention. And with that, I'm going to close this session. I invite you to go to the other sessions here and other chapters and to look at the links that are going to be included in the bottom of the comments section. Thank you for your time. Goodbye.